Good afternoon, everyone. So, welcome back after lunch. My name is Allison Squires. I'm an associate professor at New York University's Rory Myers College of Nursing and the Distinguished Nurse Scholar in Residence at the National Academy of Medicine this year. And I'm glad to have you here in Singapore, and also remind you that this year is 2020, the World Health Organization's Year of the Nurse and the Midwife, and central very much to issues of aging and care for the elderly are nurses. So please keep that in mind as we think about these next 2 days. And it's my pleasure to introduce this very distinguished and interprofessional panel, one of the best parts about aging. And I'm going to do some brief introductions here. And I have leveled up to the Readers Club now, so Attitudes for Healthy Aging. So first, I'd like to introduce Mosa Moshabella, who is who invited me to moderate this panel and is a committee member. And then I will start with Alex Ezeh, to my left here, who is Professor of Global Health at the Department of Community Health and Prevention at the Dornsife School of Public Health at Drexel University in Philadelphia, Pennsylvania in the US. Prior to coming to Drexel, he spent time working at the Center for Global Development, and he's also was one of the founding members of the African Population Health and Research Center, and he was executive director there for 17 years. And it has become one of Africa's foremost regional research center addressing population, health, education, and development issues. And he was also one of the key people involved in the Lancet Commission on the Future of Health in Africa. So welcome, Alex. Then next to Alex, we have Kenji Shibuya, who is at Population Health at the King's College of London. He is currently, he serves as a professor and chair of global health, and he is a special advisor to WHO on health system metrics, and as well as a special advisor to the Japanese Ministry of Health. To the left of Kenji is Ursula Staudinger, who is a lifespan psychologist and aging researcher with a strong interprofessional collaboration track record in both research and education. She is the founding director of the Robert N. Butler Columbia Aging Center, and also has served as the chairwoman of the board and the Federal Institute for Population Research, and is advising governments around the world on issues of population aging. And last but not least, we have Alana Officer from the World Health Organization. She has worked all over the world, mostly in low and middle income countries, and brings that perspective to this panel. She joined the Department of Aging and Life Course at WHO in July of 2014 and led the development of the World Report on Aging and Health. She now works to lead the Decade of Healthy Aging at WHO and a new unit which is working on monitoring demographic changes in healthy aging. So a round of applause for our very esteemed panel. So the theme of our session this early part of the afternoon, and we will be aiming to keep you awake because we know it's right after lunch, is we want to be talking about maintaining the robust health of aging people. And we want to be thinking about innovative strategies and interventions that promote health and prevent disease. We want to look at what are the salient enablers that work toward those issues. And we want to examine approaches that ensure that care providers have adequate training and tools to empower that to deliver and monitor the health of older adults. And we also want to understand the roles and responsibilities of different stakeholders in investing and financing health promotion and prevention. So we're going to start off this session with a question for each person, and they'll have 5 minutes to answer. So Alex, to begin with you. In Africa and around the world, urbanization is dramatically restructuring the nature of cities, with a large proportion of this population living in informal conditions without access to basic services or public amenities. This situation is compounded by social and economic vulnerability, resulting in health inequities. Considering the complex burden of disease and high levels of health inequity in such populations, urban health and urban health equity have not yet emerged as a major research and policy priority. How should countries address this challenge and develop a research and policy agenda that harnesses urban environments for healthier aging societies?
Thank you, Alison. It's really a pleasure to be at this meeting and in this panel. I think it is clear that inequality and growing inequity, it ranks alongside climate change as one of our existential challenges to our civilization today. And when you think about inequality, it is most visible within urban settings. You've seen some of the demographics this morning of the population change, but the other side of that population change is that almost all that growth that you see will be occurring within urban settings globally and in different parts of the world. Within Africa, the basic challenge of rapid urbanization has been the growth of slums. And we've done some work to show, indeed, that slum populations, not just in Africa, but in different parts of the world, actually have the worst health outcomes compared to any other subgroup. In a recent Lancet series we did on slum health, we made a point that slum health is actually different from urban health and different from looking at poverty and health generally. That it derives from the shared social and physical environments in which people live, and that's what we call neighborhood effects. And that's really critical in trying to address the situation of slums. But there is one big obstacle to doing that. And that obstacle is the invisibility of slum populations in most of our global and national data systems. If you think about it, what do we really know about slums and the people that live there? We know that slums exist within space, and there is a geography to it. And that's one of the challenges within in dealing with this. But a lot of the data that we have on slums come from a social definition that looks at households that lack certain amenities and basic services and security of tenure and all of those. But it doesn't really define the space in which these people live. So in trying to deal with that, one of the ways to do that is to remove that invisibility. And one way to do that is basically, what if we can look at, say, the 2020 round of censuses, and we can introduce a simple class identifier for urban clusters that will tell them whether they are slums or non-slums. All of a sudden, we'll move away from this binary definition of urban-rural settings to looking at slums, non-slums, and rural areas. If the reason why we differentiate rural areas from urban areas is the fact that their indicators are different, then the fact that the indicators for the slums are even worse than rural areas means that what we know as urban indicators is meaningless, because it's just an average of what you get from those different groups. So that's one of the things I believe that we can do. From my 20 years of working in the slums in Nairobi, I think there are quite a number of things that we can summarize from those experiences. The first is, if you look at the basic knowledge we have of the burden of disease profiles, and you do that for slum populations, you'll be surprised that it's actually completely different from whatever we know of disease burdens in any population. Imagine a setting or a population where 40% of the disease, of the deaths, come from one source, injuries. And you have no public health program, no health program at all that address injuries as a major cause of death. How do you improve health within those settings without dealing with something that accounts for 40% of the deaths? And the other is the fact that we try to implement or borrow policies and programs and things that we've done in other settings like rural areas and other non-slum areas, and we expect them to work within slums. The truth is, they don't often work because of the social context within which these places exist. So understanding what types of systems and processes that work for slums, whether you look at health, you look at education, you look at security systems or financial systems, is quite critical if we're going to deal with the issues of slums. You know, one of the other things we observed is that if you look at slums, and we've talked about the invisibility of slums, actually the most invisible part of the slum population are the older people. why are they the most invisible? Because if you think about the major sources of data that we have, like the national surveys, we look at women of reproductive age and we look at children and all of those. For older people, they are not in these places. But they're also invisible physically because many times, especially if it's also combined with disability, they don't come out. And we've done a lot of work to look at what is it that drive poor health outcomes within the slums. And I just want to pick up 2 key points here. One is, the nature of slum environments and the gendered nature of aging within those settings makes it creates an avenue for us to really begin to break down what are the major drivers of poor health within the slums. For the work we've done looking at the older people in the slums, it was evident that for the men, actually, they face a lot more challenges than women because they lived a lot of their lives outside of the community, working in different places. But when they get old and they are down there, they've not built the type of networks that actually support and sustain sustain health in older ages. Yet, we have an assumption that people in the slums, traditionally, like in Africa, if I pick that, is that a lot of people depend on family support systems and their communities. But if you've not invested in those communities, you cannot depend on it in old age. So you have men growing up in these slums with absolutely little or no care. While for the women, because they've lived there, they have children and families and all those, they are more likely to actually get support within those. The last point I want to make within here is, when we look at a setting, particularly from the African context, where traditional systems are collapsing in terms of support for older people, we have to rethink how, and the social systems are not there. The situation of growing old in slums, we used to think that the people get old in urban areas and they move to the rural areas. The reality is that they are growing older in the slums and in urban areas. They are not moving away, and their situations require attention. So for us, if I think what can people do, I think one is to make them visible in our national systems and then be able to design systems and programs that work for them where they are.
Thank you very much, Alex. We'll next go to Ursula. Evidence has supported the concept of a heterogeneous aging process. Beyond what societies consider to be later life, what have you seen in your field illustrating the possibilities of building and maintaining capacity across the life course to promote healthy longevity? How can intergenerational solidarity and cross-generational participation contribute to helping build and maintain capacity in aging people, especially in light of what we just heard from Alex?
Thank you, Alison. Big questions in 5 minutes. As a lifespan psychologist, I have been studying the way human aging unfolds as a sequence of interactions between the biological forces that are engulfed in our genes, the contextual exposures that we make for our life, make for ourselves through our life courses, and finally, our decisions, our behaviors, and none the least, the attitudes and values that we harbor within ourselves. And it's out of these interactions that the aging process emerges. And this brings with it this enormous modifiability, what I've called the positive plasticity of human aging. Now, in those 5 minutes, I'd like now to dig deeper into one domain, into one context, which is crucial for our adult life and for our aging process. And that is work environments and work biographies. So they are crucial exposures, or often overlooked in their impact, in their cumulative impact on how we age. Why is that? The labor sociologists have actually calculated how much time we spend of our adult life in labor work environments, and it is not more, not less, but 1/3 of our adult life we spend in work environments. 1/3 we actually spend in sleep, and 1/3 we spend in private life, leisure, and whatever, a family. So that's a massive exposure. What we do at work or don't do at work impacts whether and how much we have to think, what we think. It impacts how much or whether we have to exert our bodies or overexert our bodies. And finally, it also impacts with whom we socialize, with whom we interact. So it becomes a major part of our social life. So we cannot underestimate the impact of work. And we have started to study this from a developmental and an aging perspective. And one of the most solid pieces of evidence that has emerged over the last, I would say, 2 decades from longitudinal work as well as experimental work is that the degree of complexity that we are exposed to in terms of dealing with information and data or dealing with people impacts how our cognitive aging trajectory unfolds, i.e. the higher the level of complexity with people and data, the more mitigation and attenuation of our cognitive decline trajectory. And now you say, oh, that is all good news for all of us here in the room. Of course, you think, okay, how complex is my job? You come out with the answer, pretty complex, so I'm doing fine. But of course, there are 70% in the labor market that are exposed to less complex jobs. And so in our own group, we were trying to promote a diversification of this notion of complexity by looking at what we have called novelty processing. And you can do novelty processing at each level of complexity. Even if you're less educated, you can be exposed to novelty on your job that is less complex, but nevertheless you may have a little change in your work task, and that presents novelty to you and your brain and your motivation. And so it may help your aging trajectory. And indeed that is what we find, both experimentally, and we have now replicated it using HRS data to show that people across their work biographies being exposed to higher levels of novelty processing at work at various levels of complexity are better protected, are better able to buffer the cognitive decline. So I think this shows us a way to think about interventions. It's a very easy way to intervene for any type of employer, for anyone who is responsible to create work environment for other people, to just make sure that there is once in a while a change in the work tasks that people are confronted with. And they can be smaller changes. They don't have to be major changes. Of course, they can also be major changes like retraining, but they can be very small. Now, when we go from the work organization aspect to a more macro aspect and think about life biographies, work biographies, then of course it makes you think, how can we create incentive systems that allow people to move in and out of the work life into a learning life, a training life, into a private life, a sabbatical life, in a much more normal way, while continuing to be insured. Of course, that has to be guaranteed. Otherwise, we end up with people who have very, work biographies that will not provide subsistence in later life. So these types of models have actually been calculated by economists, and it's possible to show, if you work with tools like working hour accounts, you can make it possible that people save on their working hours, and then they can cash them in terms of learning episodes, in terms of sabbatical episodes, while still being insured. So there are ways to actually move forward with these types of life course changes that are necessary. And I've touched upon it, that this, of course, requires, besides the labor market institutions, another deeply ingrained institutions in our modern societies, and that's the educational system, to change apace. We need to expand the educational system to cater to all decades of life equally, with the same quality, with the same scrutiny, which we are currently devoting to the first 20 or 25 years of education. Now, let me, before I close, move to one other aspect, and that is that Of course, besides our bodies, the physical exertion, and our minds, the cognitive work that we do, there is an emotional and a motivational side to our being. And the novelty processing that I mentioned before is actually has a positive feedback here as well, because we find that people that are exposed to moderate changes more regularly maintain their motivation to a much better degree than people who are in over-routinized jobs and really lose their interest. And so when we think about longer lives and expanding our work biographies by interspersing it with learning episodes and sabbatical private life episodes, we can also think how this may make it possible for older adults to recreate purpose and meaning in their lives by either engaging in paid work or engaging in volunteering, work, but having the energy and the motivation to do so because they were not exhausted before their time due to too much density between the ages of 20 and 50, which leaves you completely exhausted and unwilling and unmotivated to continue to participate. Thank you.
Kenji, you're next. Your research has assessed and projected trends in population health across a variety of socioeconomic, political, and developmental contexts. Based on the evidence gathered in your field, what critical points need to be targeted to enhance health and well-being across the life course to support healthy longevity in aging people worldwide?
Thanks, Alison. So as a last-minute substitution of our Chinese colleague who couldn't make it here due to novel coronavirus, and also as a strange Japanese who moved to the UK at the time of Brexit, I would like to focus on my Japanese experience. So first one is about, Japan set a very ambitious goal of extending healthy life expectancy and also reducing health inequality in 2013. And I was academic, I understood it, but we did a very detailed study by prefecture, it's a state in Japan, and the burden of disease over 25 years. And as Jay's prediction was correct, the healthy life expectancy has been plateauing, and there is a stagnation of the improvement of healthy life expectancy these days. And also there is a widening gaps in healthy life expectancy across prefecture as a state. So Japan is obviously in the phase of declining marginal returns in terms of healthy life expectancy, but we have not been successful in terms of reducing and also reducing gaps between life expectancy and healthy life expectancy, and failing in terms of compressing morbidity. So we looked at the determinants of this, and as usual, we looked at a bunch of detailed regression model looking at the distribution risk factors, and also resources available in each prefecture, not just money, also human resources, and also system efficiency and social determinants. Overall, risk factor distribution didn't experience much of the variation, so as resources. So we're looking more on the health system performance and of course social determinants agenda. And the second example is I chaired the advisor panel for the health ministry at the time when I was an advisor to health minister 3 years ago. And we looked at, we exactly for what John suggested in the morning, we looked at future vision and moonshot type of activity. And retrospectively, we proposed what we should do now. Because if we propose something very controversial right now, always Japan Medical Association attacked us. So instead of doing it, we looked at, this is just for issues after 20 years, you don't have to worry too much. But actually what we proposed was what we should do now. But by doing so, we proposed three things. Obviously, shifting health system into social system. And we emphasize three things. It's value-based, so empower people through social determinants, and focus on global health. And since then, Japanese health system has been transformed dramatically. And next year, in 2016, the UK published a report, UK Academy of Medical Science published a report, UK in 2040. When I just read it, they just copy and pasted what we did. But the message was the same. They shifted the focus from the public health, the usual public health, to the health of the public. So it was a shift from usual health system into social system. So more or less the direction are kind of converging. But the question, what we should do? So last year, this is my final example. Last year, I co-chaired, thanks to the guy Nishikawa-san sitting there. There was a Future Innovation Working Group organized by both Ministry of Health and the Ministry of Economy, which is quite rare because the Ministry of Economy would like to deregulate and the Ministry of Health would like to regulate. It's very hard for us, for two ministries to work together. But it was an exception because they looked into the 24 vision about future innovation in healthcare. And again, the tactics is not just talking dreams. They would like to come up with the fundamental proposal, what we should do now. Backcasting is crucial. And initially we focused more on the technologies, but eventually when we went through the discussion, the issues about the communities, inclusiveness, mind-body integration, and me as a doctor, my own doctor, and social cohesion, not just technology. A bunch of discussion about more on the community and life goals and platform ecosystem. So we end up with the three recommendations. One is obviously investing, very cutting edge R&D, but with a long-term view. But more important, the second recommendation was empowering individual, harnessing inclusiveness and mutual support. And thirdly, we end up with developing a social ecosystem would be much more fundamental. That includes incentive, payment scheme, that kind of stuff as well. So it was quite, a great running scheme. I'm not answering your question because I was a last-minute substitution. Hopefully, this is just a food for thought for this discussion. Thank you.
And now to Alana. So considering your contributions at the WHO, including various initiatives on age-friendly environments, healthy longevity, and disability, how can conversations on healthy longevity expand across generations, various fields, and the life course to enact a future of healthy longevity?
Thanks, Alison. It's great to be here. I wanted to pick up on one of the cross-cutting themes, actually, on ageism. So I think if we want to even imagine, let alone build the future we want, we're going to need to change how we think, how we feel, and how we act towards age and aging. So the conversation and I think the collective action has to be on confronting the injustice of ageism across generations. So as David said, aging is not the problem, but ageism certainly is. So while the word was coined by Robert Butler 50 years ago, WHO defines ageism as the stereotypes, so how we think, the prejudice, how we feel, and discrimination, how we act, on the basis of chronological age, or the perception that somebody is either too young or too old to be or to do something. So it plays out at a number of different levels, and we've heard a lot about institutions today, but also at the interpersonal level and at an individual level. And at the moment, unfortunately, ageism is built into our systems and our institutions, those that shape our lives, whether they be in education, in healthcare, in labour, or in the media. So age bias in recruitment. I'm not going to give that job to that person because they're too young to be able to take it on. Or mandatory retirement, in the sense that they're too old to continue to do a job that they were doing perfectly well the day before. A really common examples of ageism, for example, at work. Our health and social care systems also sanction ageism. A recent systematic review that was done by Becca Levy's team in Yale, found that the sort of health and social vignettes that they found, so they were in 8 countries, that both medical students and practitioners made clinical decisions that limited patients' access to healthcare based purely on their age. not at all on their healthcare needs. Even if we look at an example there was a US hospital study on over 9,000 hospitalized patients, and they found there that healthcare providers were significantly more likely to withhold life-sustaining treatment for older adults than they were for younger ones, even when they controlled for patient preferences, for prognosis, and for actual care preferences. Ageism also operates at the interpersonal level, even if it's prejudice that we see in disrespecting and patronizing older adults, not enabling them to be involved in the decisions that affect their lives. But if we also inculcate and take on lots of those negative stereotypes about age and aging, dependency and frailty that are so commonly portrayed in terms of older age, and we actually inculcate those into ourselves, we know that it increases. So if you believe those age and negative stereotypes, it increases risky health behaviours, so more likely to smoke, to drink, to not be compliant in terms of medication, and to have unhealthy diets. It decreases physical, mental, and cognitive health. And studies from Germany, from China, from Ireland, from the US, complement a number of numerous studies, experimental studies, that found that ageism is predictive also of cognitive performance of older persons. It slows down recovery from disability. So a review also by Becker Levy found that older persons who held negative age stereotypes were 31% less likely to recover from severe disability than those who were more positive about getting older. And ageism affects how long we live. So 10 studies that looked at ageism in Australia, in China, in Germany, in the US, all found that ageism predicted a shorter lifespan. So clearly, ageism requires a life course approach with a very strong focus on inequity. Ageism starts really young. So children from about the age of 5 already recognize the age stereotypes within their own culture and context, whether they be older adults as being dependent and frail and grouchy and sick and, but yet, to the rest of us, most of us, it still remains an invisible problem, one that is socially acceptable. We tend not to question the negative representations that we see of older adults in fairy tales, in movies, in what we read and what we see. And ageism has been consistently increasing over time. It has no geographical boundaries. A recent systematic review found that ageism affects health, looking at studies from 45 countries and over 25 years, with increasing significant health impacts over time. Anybody can be ageist. So we have found ageism across age, across sex, across race, across geography. And ageism further exacerbates inequalities. Older people who are less educated tend to experience adverse health effects due to ageism more than those who are better educated. But we can change social norms, which is great. So going forward, we really need strategies that are going to raise awareness, public awareness, that ageism exists, that it affects all of us, and that crucially that it is built into currently our policies and our practices, but that they can be identified and they can be changed. So if, and at least my vision of the sort of future back is a world for all ages, and that's going to require that we all change how we think, how we feel, and how we act towards age and aging as a foundation for anything else that we try to do. And excitingly, there was a recent systematic review that was published last year with WHO's support, which showed that there are interventions that are effective in reducing ageism. So, education and intergenerational contact are the two most effective interventions at the moment. You do them together, and you're much more likely to be effective at changing attitudes, changing people's level of comfort. Unfortunately, they don't do very much for increasing people's willingness and interest in working with older adults. So there's still a lot of work to be done. But I think an exciting opportunity is the decade of healthy aging, which is going to start this year, we hope. It will be discussed on Wednesday of this week, at least I hope not beforehand, because I won't be back before then, by the Executive Board at the World Health Organization. And tackling ageism is one of the 4 action areas that have been identified as really an important investment for the next 10 years. WHO also will release a report this year, a global report on ageism, which will look at what we can do to address ageism going forward. Thank you very much.
So thank you to the panel for that opening round. We're now going to shift gears and sort of pull together what everyone has highlighted, from Alex making the invisible visible, from Ursula and the importance of work, for Kenji with social care, and Alana around ageism. I think a group that we can talk about are those who are migrating or displaced as an interesting opening place. So what we have globally around the world, the number of forcibly displaced people, both within countries and across borders, grew by over 50% in the last decade to 70.8 million in 2018. As we see many countries facing various challenges due to migration, what are the implications of migration on older adults, not only due to displacement, but also due to family migration to states with different health systems? Alex, we'll start with you.
Thanks again, Alison. I think when we think about migration, particularly in high-income countries, we only look at one part of it, which is the movement from low-income countries to high-income countries. But majority of the movement is actually occurring within countries and within regions in low-income countries. If I look at Africa, a lot of the movements, maybe even for economic migration, people might be looking at moving from west to south or east to south in different directions. But for the more conflict-related and first types of migration and refugees and all of those, they're actually within regions. Whether you think about how many Somali refugees are in Kenya for years now and all of those. So, but we also look at those who are in camps, but we forget also the fact that majority move in within the countries, and they end up largely in cities as well. And when they come in there, where do they go in? It's still within those settings. So it's really understanding those dynamics and understanding how do you deal with those. In such movements, particularly when they are not planned economic movements, you realize that the people left behind often are older people. And one of the challenges of rapid urbanization in Africa is the changing demography of rural and urban areas in many different ways. For what we have seen in the slums, again, just drawing on some of the points that's been made, one of the things we found useful that we have to think about is how do we draw on the resources of people within the context in which they are in any single program that we are looking at or interventions. I can give you examples of what we've tried to do in the slums that has really had some of the significant impacts for older people, for instance. One is thinking about how do you get them reconnect with the community and actually offer themselves and services. If you have, like, one of the biggest challenges many women face in slums is the fact that when you have a child, there's you really have to struggle between childcare and working because you do a lot of informal work, you don't have maternity leave and all of those. What if you can get these older women to provide community care for these children so that they are supporting the younger women to go and work afterwards, and then they're able to, just that opportunity to interact with younger children changes their whole perspective of the value of their life and their context and the environment, and that transforms them. All of a sudden, you have a new lease of life. You see yourself as useful, as important, as playing a role in life. And it's trying to look at for those small opportunities where we can leverage the structures and the opportunities that exist and the resources that exist within context to offer things that work. Another is, I think it's been picked up about intergenerational dialogues. Just getting to talk about, you talk about ageism. If you have younger people and older people in the same community meet and talk about how they perceive each other, you'll be amazed what comes out of these conversations. And then thinking about solutions, how do we move forward? We are all in the same community, and yet we are actually completely isolated and separated from each other. We have conversations that do not intersect in many ways. And by facilitating those types of conversations, all of a sudden you begin to see opportunities and places where you can actually intervene and make a difference. So in thinking about the effects of migration within these populations, I think one of the things we were looking at, even for migrants within slums, what are those resources that exist within there? How do we incorporate them as part of the solution to whatever we've identified as a health challenge that they face? And when we do that, we actually break new grounds and find new opportunities that make that are more sustainable within their context.
Anyone want to go next, or should we go down the line?
So I guess I just wanted to add one point, is that we often forget about the strengths of older people and their ability to, their resilience. I'm just thinking of many older Rohingyans, in Myanmar, who have been displaced multiple times. And yet, because they've been displaced multiple times, they've also learnt how to recreate their lives, how to build and maintain their families and their communities, and how to build back. So I think one of the things is just the point of not negating the great strengths that older people have in terms of being able to manage also displacement.
Well, I wanted to add that I think in particular, the notion of labor migration brings to the forefront the disruptiveness of these migration processes to an institution that was mentioned this morning, i.e. the family. We do know that China is in particularly burdened by that. And so I think it makes us think, yes, the family is very important. However, there are processes that are undermining the power of this institution. And as we will be unlikely reconstituting the family in all cases, I think it is very worthwhile to think what are complementary institutions that could take on this role that the family took on earlier. And it's pretty obvious what it can be. It's the community. It's the neighborhood. And I think it will be crucial for the future of longer lives and aging populations that we think seriously about implementing a notion of neighborhood in a century of urbanization. So really deny the fact that because we are urbanizing, there is no room for community and neighborhood anymore. It's the opposite. And that's why I really applaud the initiative here in Singapore to think about what they call the health districts, which is very much neighborhood driven, and try to create infrastructure that enables and makes it possible for individuals to interact and support each other beyond kinship lines. I think it's really crucial.
Nothing to add? Well then, Kenji, we will put the next question to you. So in terms of, as we're thinking about the changing nature of what health systems experience with older adults and including those who have migrated, in terms of financing, what are the critical points stakeholders should target in financing sustainable healthcare and public health systems and interventions? Can we reach equity, equality, and efficiency?
Yeah, so financing is a big topic, of course. It relates to incentive a whole institutional change, along with the mindset change. But going back to Japan, so we are in the middle of huge debate about social security reform. It's not, primarily we are focusing on how to sustain the system, pension, medical care, because of aging. But right now we are discussing social security reform for all generations, because there is a trade-off between investing in education versus investing in elderly care. And it's becoming a huge political battle. And this issue, again, it's purely life goals. It's not just medically, but also institutionally, financially, politically. So we are now in the middle of this huge political battle in terms of intergenerational. And obviously, because of, ruling party heavily depends on the vote from elderly people, I'm very pessimistic. But still, we are in the middle of this huge debate about social security for all generations, not elderly care.
Would anyone else like to comment?
Sure. I'm going to harp on a little bit about ageism, because I think we need to challenge our perceptions about aging and the sustainability of healthcare. So, I mean, yes, per person health expenditures are generally higher among older persons than they are among younger, particularly in developed health systems. And so policymakers tend to assume that because that's the case, that ageing is going to result in unconstrained growth in health spending. But recent studies, at least from the WHO European Observatory, found that, in fact, population ageing, and I mean this has been, reported elsewhere, is not and will not become a major driver of growth in health expenditure. So unless we challenge the sort of thinking around older people and health, we're not going to be able to move this agenda forward. And particularly there are incredible opportunities in low and middle income countries and in countries where they do not yet have large proportions of older people, where it looks like that the costs of coverage and access to services for older people is completely manageable now. If countries start making those investments over the next 15 years, it's likely to cost about, there was modelled in Indonesia sort of 1.6 percentage points per average, per person per average growth in investment, if it's spread out over 15 years. Completely affordable, yeah? Even for low and middle income countries. So we need to challenge how we think about age and financing, or older people and financing.
Yeah, you just stimulated another thought for this question, and it's really, I think when we are living in societies of longer lives, we need to reconsider our priorities on a state level, on a society level. How are we thinking to maintain bodies for longer lives with less money? It's silly. Rather, I think we need to seriously invest in that capital, which is our body and our mind, and we need to have the money for it. And it has nothing to do with age 60 and older. It starts at birth and actually before birth, as we do know. And apart from health, the second priority in terms of human capital maintenance and growth is, of course, education. And those two priorities in societies of longer lives, there is no way around it and no excuse to not fund them. I mean, picking up on David's point about wider notions of welfare, that's where the welfare is located, in health and education.
Just to underscore another point that's come out today that we really have to pay attention to with respect to this is the fact that if you look at the population aging in different parts of the world, is driven largely by very low and below replacement level fertility. Africa is completely the opposite, where the population is expected to double in the next 30 years and also almost double again by 2100. So almost all the future population growth that will happen globally will happen on the continent. And when you think about it, in the next 30 years, it means we have to double the number of health workers, health facilities, schools, teachers, roads, houses, every single thing that's been made today over the next 30 years in order to maintain the current inadequate levels of coverage of those services. So the current financing models cannot work. When we depend on international and multinational agencies to drive development discourses and programs and planning across the continent, it's not going to work. It's not sustainable. There is no amount of investment we put in that system to make it deliver effective coverage to the population. So we have to completely rethink, how do we do this? And how do we build and support and strengthen local institutions to begin to take greater charge in these areas? We've talked about a lot this morning about institutional change, and I think it's needed more than ever within the African continent to begin to rethink how we actually finance and manage the delivery of healthcare, because the current model definitely will not work with the rates of population growth on the continent.
So with that question, are health spending caps in countries, are they too low? With the caveat they should not reach the same level as they are in the US.
I think African countries adopted the Abuja Declaration, thinking about 15% investments of our GDP in health. Nigeria, which is Abuja is the capital of Nigeria, which is the place where this agreement was reached. We were in London last week looking at a Lancet Commission on Health in Nigeria. And basically, the evidence is that less than 4% of the GDP is being spent on health. How can you really deliver healthcare to 100 million people with a total health budget of 20 billion a year? Everything, not just government and all of that. So it just does not work. We can't even move to 5%. So it's really rethinking and again, countries are struggling with a lot of many other challenges. You're dealing with security, you're dealing with education, you're dealing with a lot of other things. And the question is, for me, is understanding the role that the demography plays in all of this. Because unless we get a handle on that, then we will continue to almost chase our shadows. No, I will not be able to get where we want to go.
So building on the theme of disruptive innovation, what are the disruptive innovations that need to happen in terms of all of your areas of expertise to not do things the way we've always done them? Who would like to start?
I can go ahead. I think, the point I've made before, I want to underscore it, that one of the disruptions we have to do is to change the funding model completely. The international development assistance that we've done through multiple global intermediaries and all of those has not delivered development outcomes on the continent, and it will not do it. So one of the disruptions is to see how do we break that down and move into a process where we could actually work with organizations and entities that are much closer to the ground and are able to find other solutions that we would not see from 36,000 feet above.
Yes, I was just going to say that I think that goes on the board there. Yes.
Yeah, so one of the, the grand challenge thing would be a good sign for you to move ahead. But when we talk about innovation, people are talking about technology aspect of it. But when we talk about the system innovation, we end up with talking about integration, preventive focus, or people-centered approach, blah, blah, blah. But we have been talking this for the past 2 decades or so. So what's wrong with this health sector? Because other sectors, integration, cutting-edge technology, diffusion of it is much faster than it. Of course, the health sector is very, very different in terms of market failure. We are dealing with life and death. Lots of regulation. But, David mentioned the mindset. So innovation, system innovation, we have been talking about the exactly the same thing for the past decades. But why it's not happening in healthcare compared to other sectors? So that is, to me, is more fundamental question.
I would like to mention 2 disruptive innovations. also not in technology. And the first one is actually if we would manage to implement the parallelization of those three major domains of our lives, which is education, work, and private life, moving away from the sequential organization that we are used to, having education on the beginning, and then all work in the middle, and then all private life in the end. If we manage on a societal level to move to these three domains of life, working in parallel all through our lives, this would be major disruptive. And it would have so many positive health implications, because we do know that staying in work is very helpful because we are physically more active, we are cognitively more active. So it would have all sorts of positive payoffs for a lot of the so-called aging challenges. And the second disruption, in my mind, is urban environments. I think, and I have learned this from my colleagues in public health, if we have learned one thing about behavior change, it is not to believe in the sustenance of self-regulation. Self-regulation works until it doesn't work and it breaks down, and it has a tendency to break down very easily in moments of stress. And if, however, we are living in environments that actually don't leave us a choice, so for instance, walking rather than driving, or walking the stairs rather than taking an elevator, to make very simple examples, this will have such a major impact. So in modern urbanization, to counteract our sedentary lifestyles would be another major disruptive innovation.
I mean, I think in the previous panel they mentioned a couple of things which I think are worth reiterating, and that's moving away from a narrow definition of what we understand as health, as just being equated with disease, towards building people's capabilities to be and to do what they have reason to value. So I think thinking that way is disruptive. For example, with the health sector, if it's working with other sectors to safeguard health and to foster people's capabilities and not only provide care. So if the health system is responsible for health, and then that also is going to be a disruptive innovation in that sense. But I think that firstly we need to make those investments across the life course, and address the determinants of poor health, so investments to prevent disease and disability and promote health and functioning, absolutely essential. We need to make investments and innovations in health and social care, and in how health and social care actually connect. Really, really important if we're going to get the sort of transformation we want to see, especially where people live in their communities. And thirdly, I think we want to make investments to really foster health and well-being, but do that through broader social and economic development, which is actually really important. And picking up what Ursula and Alex have said, the importance that those investments are happening in neighbourhoods, in communities, where people live, where people work, where people play, where people age, is absolutely essential if we're going to create positive change.
So before we move to the audience Q&A, a quick 1-minute response from each of you, which would be thinking about a policy or practice in your area of expertise or that you've seen over time. What is the one thing that you would like to see changed or advanced in a policy or practice to maintain the robust health of aging people?
In my area, in terms of burden of disease and health metrics, we did it final recent round of global burden of disease, and in it we see public health is failing because other than tobacco control, we see opioids. We are failing metabolic and behavioral risk factor modification, or could say air pollution. So there seems to be an expansion of morbidity across the globe. So public health, in a classic way, we are failing. So it's closely related to life course approach as well as aging issues. So we have to be very, very careful about the classic public health approach Is it better to move to the health of public or social system or multi-sector collaboration? It's easy to say, but in a concrete manner, something has to be done with the classic public health approach.
For me, I think one area for policy change, at least within the African context, is being able to develop, implement policies that actually recognize the vulnerabilities and the capabilities of other people, and move away from the assumption that families and communities are taking care of the other people. I think that might have happened 10, 20, 30, 40 years ago. Since the 80s, with the impact of HIV/AIDS, with urbanization and all of those, the context of support for older people has changed completely, and yet policy has not caught up with that. And recognizing that, and the African Union has a policy, but many countries have not adopted that and developed something within those. So I think that would be a good starting point for policy change.
So maybe just picking up on what Ursula said before, I think one of the policy and practice areas which I think has been particularly successful and interesting is around the sort of broader age-friendly cities and communities. So WHO supports a global network of age-friendly cities and communities with 1,200 cities and communities in 42 countries, covering about 260 million people at the moment. That is enabled by 14 strategic partners that provide technical assistance, support and training to cities and communities to become more age-friendly. But I think it's an area where we've seen, I love it because the strength of that work is in those cities and communities and the people who are creating those communities. And our role in terms of WHO is more about support for continued learning and networking and exchange so that other people can learn from those. But I think that that's a really interesting opportunity because it's looking at where older people live within their neighbourhoods, within their communities, and how can they be better places in which to grow older. I think that there are gaps. I think we need to better measure the outcomes of those investments that are being made in cities and communities. I think we need to be clear about who's benefiting from those efforts and who's being left behind as a result of them. But I think it shows great promise for further expansion around the world.
I think that cashing in on these for a long time, in all, political statements, we hear about the importance of lifelong learning and training, and it hasn't been cashed in. And I think it would be a major policy change if we were to develop sustainable financing models of lifelong learning that enable each and everyone to participate locked in pace with establishing a quality management system for offerings in the lifelong learning market, which is currently pretty much uncontrolled outside of universities, which is a problem. And so I think these two, if we manage to do that, that would be major.
Great, thank you all very much. We will now shift to audience Q&A. We have 2 mics on either side, and we also have people to pass. So yes, thank you.
Thank you, President. I'm just very interested in Dr. Staudinger's presentation about the novelty in terms of how you create novelties for people with different educational backgrounds. But that can be extended to the whole of society, because I think when you look at older people, or anyone, people really aspire to learn. We grow even as we grow older, we continue to want to grow and develop and contribute. I think so when we measure the capabilities, we also need to look at the opportunities for people to use those capabilities for healthy living. And when you look at the domains that you talk about, the 3 domains you referred to, there are 2 others which you might want to consider. One is the domains of personal life that society values, right? So a person can be at home, the homemaker, that's personal life, but that's a contribution. And that contributes to the capacity of the children, education of the young children, upbringing. So if and the 5th dimension is the reward systems. how do we reward the things that we value? We only value people in terms of so-called formal work. What about those contributions that contribute indirectly or directly to the capabilities of society? So the whole economic system has changed. So unless we think about that, we'll continue to be stuck in terms of our traditional ways. So because there are many people that their resources, we waste all these human resources because we don't have the methods to enable them to learn. Because people with low educational backgrounds, perhaps not as intelligent as we are, they want to learn as well. They can contribute in different ways. How do we value that in society? In every little part of their contributions. So we need to quantify those, and then our economic systems and our reward systems must change entirely. Otherwise, we'll just be stuck where we were. And I think also that goes into the element about the ageism and the prejudice. So other than the thing, the feel and the act, is also the perception. Why do we perceive aging as we do? Why do we all want to be younger? I'm quite happy to be as old as I am. I'm quite happy because now I don't have to pretend. I don't have any baggage. I do exactly what I think is meaningful to me. I don't have to keep up to look young. I'm quite happy to be as old as I am. So I guess those are the perceptions that we need to understand. Why do people perceive and want to be younger? When it's as earlier we heard that we should behave the way that our age, but sometimes we forget. Because until I look at the mirror, I don't realize, oh, I'm that old, right? So because our perceptions are very much in terms of the images that are created, what we think is what it should look like. So if we change perception that people who are wrinkled like myself, age, white hair, those are things that can be created in terms of the images of people that can continue to contribute.
Are you collecting, or should we react?
Oh, yeah, go ahead, react,
okay.
yeah.
Because he was addressing my statement. So I think two things, starting with the ageism thing first, there is very fascinating research that actually shows that in countries where we see historical change in a labor force participation past age 65, you see a change in the negative age stereotype. So in these countries where more and more older adults are perceived in participating in competent positions, it's less likely that you would connect old age with being demented and being unable and being just someone to be taken care of. So it's just supporting what you're saying. And to your first point, I couldn't agree more. And I think it's very interesting and actually encouraging to see that economists have taken on this challenge to estimate the capital value of these hours that are contributed in volunteering work, but also in homemaking and of course in childcare, and have made suggestions how to bring this into a balance sheet on a societal level. Where we are falling short more is actually when we look at the corporate world, because I have been fighting this battle to show that investment in human capital within a company should not only come up on the balance sheet as an expense, but it should actually come up on the balance sheet as an investment. Just as a company invests in hardware and it can actually put it on the balance sheet and it increases the value of the company, that should also be possible if they invest in a systematic fashion in the training of their human capital. But we are some ways to go. Maybe David can help us on whether some progress has been made on that end, but I couldn't agree more. Thank you for that comment.
Anyone else? Other questions from the audience? Yes, over here. Yes.
Thank you. One thing that hasn't really come up that much, although some people have touched on it a bit, is the things that lay the groundwork for quality of life. So, of course, we've talked about social determinants of health, and I think in the first session someone mentioned resilience. But I guess I think about once you have some of these basic needs met, the health system itself can only go so far, and we're talking about kind of transforming societies. We talked about intergenerational relationships being strengthened. When I think about that, I think about things like emotional well-being and quality of relationships, like social relationships, being able to see one another and to resolve conflict and things like that. And it goes far beyond what the health system does and would probably fall better under social welfare, but typically social welfare systems aren't as strong as to be able to go that far. And things like, I don't know, things like parenting classes and really addressing violence and security and then those qualities of emotional health and well-being. So just raising that point and wondering if you have any reflections on that.
Yeah, great point. When WHO was reconceptualizing healthy aging, we tried then to understand, well, if older people are going to experience well-being, what are the capabilities that they need to be able to be and do what they have reason to value? And what we found was that older adults needed, as you said, their basic needs met, yeah? They needed to be able to be mobile, to get where they wanted to get when they wanted to get there. They needed to be able to build and maintain relationships. They needed to continue to learn and grow and take decisions, and they needed to be able to contribute. So the conceptual framework of healthy aging is about fostering those capabilities, or those abilities for people to do, for example, those 5 things. And recognizing that investing in healthy aging, you know, has returns on those investments, which are very significant, whether we're talking about better health, better skills, you know, longer working lives, taxes, consumption, better social connectivity, better personal and financial security, and personal dignity. So the outcomes and the benefits of those investments, if we can create those capabilities that definitely go beyond basic needs, are really very significant.
I can make a point with regard to work environments because I focused very much on cognitive outcomes, but I just mentioned it in passing that of course work environments can be very supportive or detrimental to one's well-being. And you know, we've learned a lot about the stressors at work, and we also learned that we are, as human beings, quite resistant and resilient in dealing with stress as long as we feel respected as individuals at work, as long as we feel that our efforts are rewarded in the currencies that we estimate as a reward, and not necessarily does it have to be monetary. And a third facet that has been found in this type of work is actually the degree of autonomy that is given to us in our work life. And again, this can be very different types of autonomy. It can be little things like deciding when I take my break, if I'm on an assembly line, rather than being forced to take my break at a given time. So there are these very little things that make people feel valued and feel better, and make them better able to withstand the stresses that are unavoidable, more or less. So that's from the work environment.
Thank you. Yes, Senator. Oh, sorry, Bay.
No, sorry.
I didn't see you. Yeah, Bay, go ahead. Okay. Sorry, I didn't see you there.
Well, since we're colleagues, I have the advantage of being Bei Wu from New York City. So actually, the panel had a discussion on migration. I think this is a very interesting topic. That our team has done a lot of actually migration related in terms of early migration, both internationally and kind of in the within country kind of migration in later life health outcomes. So it is kind of think about migration that it's very important to think about the reason for migration. That certainly in gerontological field, we have a well-known kind of theory in terms of healthy immigrant phenomenon. When people actually is for volunteer kind of migration, is for advanced education opportunities, for job opportunities. This certainly actually we have, when you look at later life, Many actually at the population level, they have a much higher and better health outcomes than the native kind of born individuals. But on the other hand, when you look at some other migration reasons for political refugees, I remember when we did a study in Boston that looked at Russian immigrants, that Russian immigrants, most actually is a refugee. But then actually, even they have a much higher level of education than actually in general, kind of higher than general population in the United States. But they have a much higher level of depressive symptoms and many other kind of phenomena. In that case, actually, Ursula, your sense of thinking about how in our community, our neighborhood, and our family, how actually can generate these kind of supportive system environment, that becomes very critical in that sense. So we think when we're talking about migration, it's really the reason for migration is one of the key factors that we need to take this into consideration. Thank you.
Thank you, Bei. Yes, no, sorry.
Can I perhaps a little bit provocative when I say it, but I come from Denmark in the northern part of Europe and a Danish welfare state. I mean, we're always talking highly appreciative of the voluntary sector. And all the trying to say, can we measure the value of family, friends, neighborhood activities, and agree it's all important. And we might measure the value of it. We can find different way of making a metric for it. But then the provocative question is, do that provide any money for activities to maintaining a good health?
Yes.
So John Ron from Singapore, I'd like to, yes, I think that the panel has offered great, I would say, challenges, but I'd like to try and refocus, I mean, if we're trying to come up with solutions, by really trying to ask, again, how are we going to take ownership of the various components raised today? Certainly I think that people depend a lot on governments, but I'm really not sure what employers are doing, say, with the data that Ursula and her group are generating. And again, are there opportunities? I look at the healthcare systems. I mean, who is actually the patient's coach in terms of a lifelong, if we really take a life course approach, who in primary care, if that is primary care's role, it may not be, but who is actually serving as the patient's coach in this journey? And then are there opportunities for entrepreneurs? We have devices like Alexa, which can give us all sorts of advice, but are there opportunities for really trying to change our current life trajectory based on machine learning and data analytics? Because I think that right now we've got a whole wealth of data and evidence, but we don't have very many actual practical implementable solutions. I like, Ursula, your 3 points, but I'm just asking again, who's going to take ownership of these issues?
I wanted just to raise the possibility of another sector in society who may well be powerful agents of change that hasn't come up yet. If we look, for example, at some of the big changes, such as reduction in the working week, to some extent pensions, length of holidays, rights for paternity leave, lots of other things, we don't necessarily find that they have happened because researchers have convinced governments that this would be a good idea. They've generally come from mass action from working people. And therefore my question is, to what extent do you think that in taking this kind of project generally forward, the working population needs to be seen as historically as an agent of change that needs to be armed with the sort of insights and information that we're sharing here? So as well as sharing it with innovators and government, why not with the working class mass organizations?
Anyone want to reflect?
Well, thank you for these great comments. I just take them in turn. So my answer to the the colleague from Denmark, and I think it's well put. The answer is that it doesn't create money, it avoids costs. So the estimate is about work that would have been to be provided by someone else if it wouldn't have been provided by the volunteers or by the homemaker or by the caretaker of the children. So I think that's the way we have to think about it. So our debts would even be larger. And to make them visible, of course, creates change in social perceptions. So I think that's worth the effort. The second point by John Wong, I'm not sure I completely understood your point, but I'll try to respond. And I think the point is very well taken that in these longer lives, all of us, we need coaches. And we need them for different things. Of course, for being a patient, we very much know that, how lost you can get in the health system. But not only there, we also need it for these journeys of lifelong work or of longer work lives and of longer learning biographies to get advice. How does our skill set fit with what the market is looking for? And if we know that, then what type of certificates do we need to take in order to make a better match? And of course, you know, modern algorithms can help us to make these matches. It doesn't have to be individuals looking at paper files. It could be done much more quickly. And in terms of the labor market, we have fantastic systems. Actually, they were created by the Department of Labor in the United States. It's a very differentiated system of rating work environments and work tasks for each occupation. And we could use such systems to actually program them and then match them with the supply side, i.e. with the workers' side. So I think there's a vast opportunity for machine learning to be implemented there.
Just wondering when you can comment why it's not, what are the challenges of it being implemented?
Well, it's actually on its way. In my mind, it's a matter of lag. We heard this morning, I think it was David, who very rightfully said, systems are there to be maintained and not change. And I think that's what we are observing, but I can report from countries where the pressure on the labor market in terms of shortage of qualified labor is much higher than, for instance, in the United States or, I don't know, Singapore labor market. And there, you know, people have become very creative to actually make these matches. And also in terms of actors, coming to your point, we see in societies where the labor markets are really experiencing shortages, all sorts of movement all of a sudden on the employer side, but also giving a much better lever to trade unions to negotiate for the working class in terms of not only wages, but also negotiating free time for learning, free time for sabbatical to take your breath and not be exhausted before your time. And so I think these drivers of change, yes, I couldn't agree more with you that the working class and its representatives, given historical circumstances of various labor markets, I mean, they have only a lever if they are in demand. It's very hard if they are not in demand. And and I think we will be, so the big issue that's currently discussed in Germany, and I think it will bring a lot of change, is of course robotization, automation, Industry 4.0, and how it will restructure the labor market as we have seen it, you know, in the 70s and 80s with moving into the new economy. So these will be drivers of change, I have no question, and we need to make sure that they will be changes to the positive.
Thank you, Ursula. And we have time for one more question up here.
Thank you. Thanks for a wonderful panel. I'd like to follow up on several points that Alex made and maybe think about them in combination. Of course, the UN Madrid Declaration of 2002 said that countries that have to put aging at the center of development agendas or risk crashing their development agendas. Alex, you made several points about the distinct issues for Africa in terms of a youth bulge and also a need for a change in financing models. And Given the conversation today about the need to invest in young people's future health span in a life course way, how would you say that Africa should be focusing on investing in health futures for young people so they arrive at old age healthy and stay healthy, because they will have longer lifespans? What should the financing model at the local level be in terms of investing in health promotion? And finally, to your point about the assets that older people bring, are there ways to deploy older people to support the health futures of the young?
Thanks, Linda. Yeah. So if I start with the question in terms of how do you invest in the health of young people going forward, I think for many people, we recognize that, and the point that we've been making with respect to population growth in Africa is not just the fact that you will have 2.3 billion people by 2050, but what type of 2.3 billion people would that be? What type of education and health and opportunities would they have? And that the time to make those decisions that will affect those outcomes then is today, not tomorrow. So that becomes very critical. But as governments struggle with many other challenges, they are dealing with that. And the rate of growth of that population size makes it harder to actually make meaningful investments in those. If you look at, say, secondary school age population today, that population will almost double by 2030. So that means any investments that we have today, we have to more than double that to be able to reach that population. So it becomes a key challenge. And we do have a great opportunity today as we talk about universal health coverage within the SDGs to ensure that health promotion and prevention services are included as part of that package. Otherwise, if we still move forward with a care-centered approach and care delivery and all that, it becomes harder, and particularly as those disease burdens become more complex within the population. So it's a huge opportunity, and for many countries, what they are looking at is how do you maintain or improve coverage and reduce catastrophic health expenditures for households, which is really one of the major challenges that countries are dealing with. I think there were, in terms of, there were questions that came up before around the social welfare. I think it was raised. And from the work we've done in slums, I think one of the key points there is really, it doesn't matter where we are still human. And part of our humanity is that we seek out each other. We want social interaction and all of those. And for many older people, that's one of the things they crave the most. You can't imagine being in a particular community where you don't speak to anybody and nobody speaks to you. And you get an interviewer that comes in and that's the first person you're talking to in 3-4 days. You want them to be there for as long as possible. And if we can create basic small programs that can actually connect them back to even amongst themselves, amongst other communities and all of those the types of interventions that could have the greatest impact within this population on the continent really are not, it's not where, for me, I think it's those basic little things that connect with people where they are that have the greatest impact. But I do agree with you that for the young people, if we don't invest today in terms of their health and education and all of those, then the challenges will be much more tomorrow because that population will continue to grow.
All right. So we have our last quick question for the panel, each taking a minute or two to respond. So based on the perspectives gathered throughout this session, what do you think were the surprising or insightful thoughts, ideas, or examples? What do you think would work to disrupt or transform your field toward a healthy longevity future? Small question.
I mean, I think the disruption's starting. We are at the beginning of a new decade, and one that that offers great promise, I think. So within the next decade, we've heard about some of our population figures. We know that in the next 10 years, there's going to be a 34% global increase. We haven't heard very much about the fact that 80% of older adults are living in lower middle income countries. Yeah, and that needs to be a big focus. 194 countries called for WHO to develop a proposal for this next decade of how we can foster healthy aging. And that's intended as a global coalition that brings together all of the stakeholders we've heard about: government, civil society, professionals, older people themselves, families and communities, such that improves the lives of older people, their families and communities. And to date, 89 governments, 300 civil society organisations and 19 international organisations have contributed to the development of that proposal that I hope will be discussed on Wednesday by the Executive Board. So I think this provides an incredible opportunity to tackle ageism, to improve integrated care, to improve long-term care, and to create communities that really foster the abilities of older adults. So I think in terms of going forward, I am optimistic that we can create some really transformative change if we work together over the next 10 years.
I would just like to reiterate that I think the major change that could make a contribution is reinventing work for the 21st century to match the challenges and opportunities of demographic change and climate change. That is a major challenge.
Yeah, so I was shocked because Singapore has exceeded Japanese life expectancy, and I'd like to congratulate that. But if we take 5 million rich people out of 120 million Japanese population, we will definitely be Singapore. But the point is not that country comparison. It is more on we had a responsibility to diffuse that kind of benefit among 5 million, or not just rich people, not just through technology, but also system, but also global collaboration. So I think there is a huge opportunity, not just technology-wise, but also system-wise, not just by country segmented approach, but also carefully looking at the segment of the society, and more worried about more on the distribution of simple metrics, healthy life expectancy.
And for me, I think there are two key points. The one is older people as agents of change in improving their health. And many times we tend to plan for them, think for them, and think of what they need. But if we actually engage them and leverage their own resources and capabilities, they might become the key drivers of those health outcomes we want to see in those ages. And the second is recognizing the diversity that exists among older people. They are not just one group. The fact that you're a 65-year-old or 80-year-old does not mean you're the same person. It depends on the context in which you are, whether not just the country, is the region, is the economic status of this person, and their health status. And looking at those diversities means that they're quite a group that might be most vulnerable. And as we think of programs, let's also find ways to ensure that those programs reach the most marginalized within that older population. I think in the slums, that's what we see the most, is that you see greater vulnerability, you see greater disengagement from society and community. And unless you work with them in that context, well, really, most of the things you design, they will not even be able to access it because they're not even getting out of the house in the first instance. So the models of care and delivery and all of this will be completely different depending on who they are and their circumstances.
And now I have the somewhat daunting task of summing this all up. So I think what has probably struck me from these conversations is obviously the complexity that we are facing with these issues across countries, but also that we can't do things the same way that we have always done them before. We know what has worked, we know what has not worked, and in order to move that forward is going to require sort of a change of attitude on our part, which is saying, no, we're not going to do things the same way as we've done them before. Because if we keep doing them this way or just making small tweaks, we're still going to be dealing with issues of ageism that are going to translate into the workplace in terms of when people are employed, how they're employed throughout their lifespan, how long they're working, how long they want to work, and then trying to figure out how do we make visible the invisible that we see in many other parts of society, whether it's slums in Africa or the slums in Los Angeles. And then figuring out how do we leverage data and the metrics that are out there, creating new ways to actually capture and study these things over a long period of time. And so with all of these things coming together, this will enable us perhaps to develop some sustainable approaches over time to addressing these issues of keeping a healthy, robust population over time. And there's so many other things to cover, but I think I could go on, but I think it's best to keep these things succinct. So in light of that, thank you very much to the panel for this wonderful discourse and a very stimulating session. And we will now break slightly early for refreshments. Thank you.